Hello and good evening, everyone. It's 8 p.m. UK time, so it is definitely start to our live event, and we do have another interesting topic. So, welcome everyone to our Stronger Together online event. And as you can see, we already have our special guest with us tonight. This is Dr. Adriàn Moreno. Hi, Dr. Moreno. How are you
Hello.
feeling?
Fine, thank you. It's a real pleasure to be here today.
I am very happy that you've joined us, of course. And just let me say a few things on our Stronger Together events. And of course, we will then go ahead with Dr. Moreno's presentation. So, of course, as you know, we are gathering here every single day from Monday to Friday to support you, to give you an opportunity to meet top fertility experts, but also fertility coaches, so that you can find out a bit on various topics. We are focusing this time on successful IVF treatment after failed attempts, but of course there are other topics that we definitely want to bring to you so that you can learn from this as much as you can. And of course, this is a great opportunity for you to simply ask your questions and get some recommendation and advice from those experts. And as always, I want to mention and thank to our ambassadors and partners. You can see them right here on the screen. And as always, they are supporting us through this Stronger Together initiative. They are sharing, they are right there with us. So huge thanks for their help. And also, of course, we will start with Dr. Moreno's presentation. And I just want to mention that he is the gynecologist specialist in human reproduction at Clínica Eugin. So we are connected today with Barcelona. And so, of course, Dr. Moreno will start his presentation on the topic that we have, which is successful IVF treatment after failed attempt. And he will be talking and explaining reproductive options for women that are 40 plus. And well, remember that this is being recorded, so you will have a chance to watch this again. And of course, after the presentation, you will have a chance to ask your questions. You can type those in the chat section during the presentation or later on, and Dr. Moreno, of course, will definitely help you out as much as possible. I have no doubt here. So that is it from me. Dr. Moreno, are you ready to go ahead with the presentation?
Absolutely.
Excellent.
Thank you,
Thank you so much.
Caroline. Thank you, Caroline. As I've said, it's truly a pleasure to share this time with you today. As you already know, first of all, I'm going to share with you a little slide presentation to discuss about the topic, and afterwards we'll have time to answer all the questions that you may have. All right. So the topic today: reproductive options for women over 40 years old, or put it in other words, maybe less suitable, advanced maternal age. Okay. Before starting with the topic, I would like to introduce you my Eugin, the group of clinics where I work. Is a huge network of clinics that it's spread widely over 4 continents with more than 75 clinics. We are in total more than 150 1,550 specialists in healthcare and reproduction. Okay, and we perform more than 50,000 cycles per year in total in the whole group. And well, that's it. Let's go with the subject. All right. So to discuss or to explain you about the current status of the female fertility, I would like first to analyze the causes of the socio-demographic situation currently that could have a strong impact over the female fertility. Okay, so currently, as you could see in this graphic, there have been a postponement on the childbearing during the last decades. Okay, I'm sorry that I could not include UK data in this figure, but as you can see in many different countries, from Czech Republic, Spain, United States, this is happening from let's say from the 70s till now. We've seen how the age of the motherhood has been postponed from, in average, 24 until now we are close to 29. And of course, this is going to have a strong impact on the fertility rates in our society. Okay. Again, if you could see here, in these different countries, comparing the decade of the 80s and currently, we could see, for example, in Spain, as the percentage of fertility. So the moment to give birth the first child, it is twice. It is the double from the 80s till now. Okay, so today we could see that giving birth at 40, it's twice more frequent than 20 years ago. Okay. Perfect. Of course, different factors could be involved in this fact, okay? But it's interesting, at least to analyze these two papers that were published in reproductive magazines, Human Reproduction and the Fertility and Sterility in the United States, where after performing a survey over many different women in different age, we appreciate that there is quite misperceptions about the motherhood and also the fertility state. Okay, trending to be excessively optimistic in regards of the capacity of the fertility. Okay, this is probably we are not going to analyze this today, but media or social, let's say, models that the society has today probably has a strong impact on this idea or these thoughts. Okay, these are by the way, all the information or the data that I will share with you today is based in medicine based on evidence. Okay, so it's not my opinion or the opinion of a group. It is current evidence that they came from randomized control trials or different studies. Okay, so this data that you see here is from my group, from Eugin, from 2018. Here you could see that almost 50% of the IVF treatments that we perform in our patients, they were over 40 years old. But if we take in account, for example, from 36 and above, almost 75% of the treatments performed belong to this group of patients. Okay, so we could extrapolate that the age has a strong impact on the reproductive results or the reproductive capacity of the woman. Okay, basically, as I explained to my patients, and we will talk about how the age has an impact on women's fertility. Okay, basically in two ways: reducing the ovarian reserves, so the availability of eggs after an IVF or after an egg stimulation, an ovarian stimulation, and also in regards to the quality of those eggs, which is even more important than the quantity. Okay, the quality of the egg is understood by eggs and spermatozoa. Basically, they are carriers of chromosomical information that will allow to create a new life. No, on the egg we will find always, when it's completely normal, we will find 23 chromosomes. Chromosomes are like suits where boxes where the information, the genetic information of each person, it's packed. Okay, it's critical that the egg we should find this number, not another, because otherwise the resultant embryo could have an impaired or an abnormal chromosomical datation. Okay, I'm explaining that because we could see here in this figure that the age has a strong impact on the chromosomical normality of the eggs. Okay, as you could see here, and it's interesting to see that even, let's say, good prognosis patients, less than 30 years old, even a third, almost 30% of the eggs produced naturally or after an ovarian stimulation will have abnormalities. These percentiles, which will reach more than 70% in patients over 40 years old. So this is giving us an idea about how assisted reproduction after over 40s could have some problems or difficulties. Okay. Perfect. So this is also an interesting slide. It talks about the subject permanent involuntary childlessness in patients in United Kingdom. Okay, based in a study from Brown in 2010. It's interesting, of course, seeing this second part here. you could see that the risk of this peak, it will be related with the age where the patient starts to look for a pregnancy. If the patient starts between 30 to 34, let's say only 6% of the patients could experiment a difficult on their desire of conception. From 35 to 39 years old, this percentage will increase till 14%. But it's important to bring up with the idea that after 40 years old, maybe 35% of this population of women will have difficulties to have a natural conception, and most of them, all of them, will need to undergo assisted reproductive technologies in order to achieve a pregnancy. All right. This slide is giving us an idea about the current test that can warn us or give us an idea about our prognosis through these different techniques. Okay, it's important to explain that this test for ovarian reserve, AMH, anti-Mullerian hormone, or the antral follicular count, they are only going to estimate the capacity of the ovary to produce eggs during an ovarian stimulation. Okay, it's not a marker of fertility. Okay, so these markers, they are not going to tell us the capacity for a person to get pregnant naturally. Okay, basically they are giving an idea about how many eggs we can expect after an stimulation. Okay, so there is the misconception that these markers could tell us if there's going to be easy or not to have a conception naturally afterwards. Okay. All right, now we're going to start talking about the different possibilities or different techniques that we could offer to our patients when they are infertile or when we have a lack of a male partner. Okay. For example, in this slide, you could see we are talking about patients that they had to undergo 2 inseminations with a sperm from a donor. Okay, and we can analyze here the accumulative chance of having a pregnancy after a determined number of cycles. Okay, it's interesting to see where patients in 40 to 41 years old, they, at least after 3 cycles, they arrive to close to a 30 to 35% of pregnancies. And even if they try more later, they even going to increase these chances on the accumulative rates. But patients over 42 years old, 42 and 43 and above, after 2 or 3 cycles maximum, we see how the curve arrives to a plateau. And we can see that there is not increase of chances of achieving a pregnancy after the 3rd attempt. So we can extrapolate that for patients in 42 years or more, there is no point, or it's pointless to perform more than 3 cycles in regards intrauterine insemination. Okay. So we shall discuss about inseminations, intrauterine inseminations over 40 years old. Could be an option, but in this slide we could see how probably IVF or ICSI is a treatment that is going to bring much better results, mostly in regards of that we analyze the time to pregnancy, so the time that will be needed to achieve a pregnancy. If we see here that for this subgroup of patients, after performing 3, pardon me, let me show my pointer. After performing 3 ICSI IVF cycles, we'll have determined success rates. And after 6 attempts of IUI, we could reach almost the same result. But of course, it's going to take much more time to arrive to the same point. So we can conclude that probably ICSI is an advised treatment for this group of patients over the intrauterine inseminations. Okay. So we could draw these conclusions. Over 40s, probably IVF is advised over IUIs. IUIs could be performed with an acceptable cumulative rates, but after until let's say maximum 42 years old. After 42 years old, truly, we shouldn't encourage our patients to perform IUI cycles, because probably it's not going to be cost efficient, and probably they could the time that we're going to lose during doing these cycles, probably this is going to have a negative impact on the afterwards treatments that we can offer to this group of patients. Okay, so IVF over 40, it's the ideal treatment. It's gonna solve all the problems for this group of patients. Could be suitable for some of them, but of course we should validate the results. Okay, so here in this slide, you could see how in this particular study, IVF performed in patients younger than 35 years old, it had a live birth rates of close to 25%. It's compared with groups of patients of 42 and 43, where you could see that the success rates, it drops significantly. But it's interesting to see that after 44, truly the chances they diminish quite significantly, and that's the reason why. Let's see that. That's the reason why probably IVF in this after 43 years old, as we're going to see later, probably is not the most appropriate or advised treatment, again, for this type of patients. Basically, and this graphic is interesting to see, here we can analyze results from our group. Okay, let's see on the last group of people, 43 years old and more. Let's see if from this is the 100% of patients at the start of cycle, almost 200. So from this total of patients, only 11% will have a positive HCG test after the embryo transfer. Okay, 11%. And you have to pay attention, because here we are describing positive HCG. That doesn't mean live birth rates or ongoing pregnancy. So these patients, they are still in risk of having a miscarriage during the first trimester. Okay, so truly, finally, we'll see later, the live birth rates for this group of people, it's much less than 11%. Okay, you can compare also, we can see here that the rates of cancellation, or the chances of having a negative result, it's quite high in this group of patients, where in the other groups it's acceptable, even in patients of 40 to 42 years old. So, answering an interesting questions for the subject that we are discussing today, after failed attempts, for how long it's worthwhile to try new attempts, new rounds of IVF. So we could see here that for stratify in different groups of patients, different age group of patients, we could see how, for example, for patients younger than 35 years old, even trying cycles beyond 4 and 5 cycles, the increase of the chances, well, after the fifth, no, but until the 5th cycle, will have an accumulative live birth quite reasonable, around 63% in this study. Okay, if we look to patients over 40 years old, we will see that after probably the 3rd round, the cumulative live birth rates, they are not increasing after even trying and trying. So probably we can conclude, let me show you the next screen, that in group of patients from 40 to 43 years old, it's not advisable to perform more than 3 rounds of IVF, because probably after the 4th, the result, it's going to be rare. It's going to be difficult to change the result, not to obtain a positive result. This is the way that after, as I've mentioned before, in the group of patients older than 43 years old, I know that this statement is quite harsh and could be discussed, of course, but attending the current live rates or chances published in the current scientific evidence, probably for this group older than 43 years old, trying IVF with own eggs is not a realistic approach, or it's not going to have enough. It's not going to be justified to use it. Okay. All right, this is I would like to include that in that speaking today, because PGTA is a tool that we use more and more every day, and in some way could help in this group of patients to optimize, or at least to have to increase the chances for an IVF round. Okay, basically the idea for the PGTA is that we are going to screen, or we are going to identify abnormal embryos, as we have discussed before, in the age-related abnormality on the embryos. We're going to identify these eggs with these embryos. Sorry. Of course, we're going to discard them, and we are going to transfer only the normal ones. Okay. Basically, this is the idea, or the intention with this, is to reduce the time to pregnancy, avoid unnecessary transfers, and reduce, theoretically, the rates of miscarriage. Okay, basically, to perform that technique, we should carry the culture of the embryos until day 5. Okay, until blastocyst stage, and in this moment we're going to perform a biopsy, taking cells from the surrounding part of the embryo. Let me share with you the next. Exactly. Here we see blastocyst. This is an embryo on day 5. So we're going to take some cells from the surrounding area, that part of here. And with these cells, we're going to identify if this embryo has or not a normal chromosomical dotation. Okay. This is an interesting idea, of course, but this PGTA should be applied, or could be offered to any type of patient. But we found from Eugin that some specific patients could have a higher benefit from this. Okay, these patients basically is when the patient is older or over 38 years old. Okay, when we had the chance to retrieve at least a good number of eggs, probably more than 10, or at the end of the culture when we have obtained at least 3 or more embryos in day 5. Okay, I mean, this is not an exclusive indication for only these people, but we found that if the patient that meets this criteria, probably is going to have a higher benefit from this technique. Okay. All right. Probably this subject about the egg vitrification, it's not applying very well to the talk today, but I believe that it's interesting at least to inform about that, because could avoid many treatments, many IVF treatments or egg donations afterwards. Okay. Basically, egg donation, the philosophy is that we offer the possibility to freeze or to vitrify eggs for good prognosis patients. Mostly could be done again in any moment, but the idea, or that should be offered always at patients probably less than 35 years old, less than 37, because in that way we can freeze the still eggs with good potential of development and good chances of pregnancy. Okay. The next slide, I believe it's very interesting to share with you, because here you could see in this graphic the relation that we found between number of eggs obtained after an ovarian stimulation after freezing them, and the chances that this amount of eggs will offer to the patient in regards or in relation to the age of this person. For example, let's hypothetically see a patient less than 35 years old, 35 or less, that has done an stimulation, and she has been able to freeze at least 10 mature eggs. Okay, we could see here in the graphic that these 10 eggs on future, they will provide close to 70% of chances of at least having one live birth. Okay, if we analyze this same amount, 10 eggs, for a patient, for example, around 40 years old, this curve here, we shall see that the rates are reduced to 30%, okay, due to the same reason that I explained before, to the quality of those eggs. Okay, of course we can compensate quality with quantity. So for example, for a patient that wants to freeze eggs, probably I will advise to try to vitrify at least from maybe to 20 to 30. Okay, this is going to give to this patient from a chance from 50 to close to 70%. Of course, that doesn't mean that this patient is going to be able to offer or to retrieve from the collection this amount of eggs. Maybe it will be necessary to repeat one more than one cycle in order to arrive to this number. Okay. All right, and this is one of the topics that that I wanted to share with you, because I believe it's very interesting in relation with the subject that we're talking today, egg donation. Okay, the idea technically is easy to understand. Basically, there will be a patient that will be the donor. Of course, that patient should meet several criteria in order to tell that this patient is going to offer a good profile for fertility. Okay, and this patient will do an ovarian stimulation as we do in the IVF, but afterwards this egg will be fertilized with a sperm from the partner or from a donor, and at the end these embryos will be transferred in a recipient, okay, in the receptor. Okay, this of course has interesting benefit, okay, for the results. Okay, when we recommend to undergo to this type of treatments, okay, when we have previous IVF failures, okay, how many we've said before, okay, or when the patient meets ovarian premature failure or premature menopause. Also, this could be a little bit controversial, but for attending the current evidence, the recommendation is this: patients over 43 years old, the primary recommendation should be egg donation when it's available. Okay, because from the medical point of view, it's not, or the results that we get through IVF with own eggs, as we said before, they don't justify to offer this cycle, this option as a first. We should offer egg donation, okay, from the current point of view. Also, when the patient has any genetic problem, inherited disease or so on, could be an option also. Success rates per transfer, in average, we are close to 60% of positive pregnancy tests per transfer. Of course, this could vary depending on the quality of the embryos that we transferred. It could go from, for average quality embryos, from 45%, 50, even until 72, 75% for high quality blastocyst, okay, in day 5. The accumulative chances, so after trying 3 rounds of egg donation, it's very high. It's close to, well, it's 93%. Okay, so it's a successful treatment, okay, for patients that requires this type. Of course, egg donation has limitations, legal limitations, because in some countries it's not legislated. I mean, it's a kind of treatment that is not contemplated, and in some others, the lack of donors different. Due to different reasons, it could make difficult to perform this type of treatments. All right. So to gather or to analyze conclusions from this presentation, current social changes has a strong impact on the reproductive profile of the women today, and we should be aware about that, okay? Because truly we found as a professionals that there is a lack of information and a lack of consciousness about the real possibilities of reproduction or motherhood in some specific moments of the life. Of course, this is due to some reasons. I'm not analyzing the reasons that why we're in front of this phenomena, but of course, I believe that from the medical professionals or healthcare, we should claim that, and we should do something about that. Okay. In regards of assisted reproductive technologies over 40 years old, some techniques offer a reasonable good prognosis, but of course with limitations. Okay, it's very important in this group of patients counseling and patient-to-patient assessment. Okay. Exactly. What we've said. Okay, we should encourage our patients, women, in not only when they are in our consultation at this moment, if not from an early stages on our work, we should encourage them to children sooner. I believe that this is very important. If that is possible, vitrification is a real option. Okay, again, the recommendation should be have children sooner, but vitrification could be also a good option for those women that they are not sure or they want to postpone this decision for the future. Okay, egg donation, this is also an important statement, is the most effective treatment. Okay, always. Of course, this has conditions that should be accepted for the patients. Okay, and one important thing to bring up with is that we shouldn't forget the obstetric risk, so the risk during the pregnancy for the group of advanced maternal age or over 40s, where we could find an increased risk for obstetrical complications as premature labor or high blood pressure disorders, diabetes mellitus, and the risk related to that. Okay, so it's very important to attend these patients and to perform or to make a correct follow-up from the obstetrician. Okay. Perfect. That was all the information that I thought that it was interesting to share with you today. So now I believe I will be delighted on answering your questions.
Wonderful. Thank you so much for your presentation. Lots of useful and important, of course, information you have just provided to us. And well, as you can see, there are plenty of questions ready. So, well, my question is to you. Are you ready for those?
Absolutely.
Okay, glad to hear this then. And let's have a look at the question that we have here. What is the percentage of women that got pregnant with their own eggs at 40 or 41 at your clinic?
It's an interesting question. Of course, these percentage could change from one clinic to the other. We should specify for this subgroup of patients that, as I explained in my presentation, that PGTA could change significantly this percentage because, of course, through PGTA, we are only going to transfer normal embryos. Okay, let's say that currently rough percentage for this group, it's around 39%, 39 to 42% of positive pregnancy tests after a transfer. If we perform transfer after PGTA, probably this percentage could be reached or could be increased until maybe 50% or even a little bit more, depending on the quality, a part of the normality of this embryo, part attending the quality, morphological quality of the embryo.
Excellent. Thank you so much for your very first question and, of course, for your recommendations and explanation to this one as well. And next one is right here from the very same patient. So are there new data about fertility in age for women? I have read that data that we have today are old. Women have evolved.
Yes, it's true that not all of the data that I offered you today, they belong to some old studies, but it's quite what we found in the current studies or in the current population that we treat is that this percentage is quite stable. Okay, it's through the IVF treatments they have evolved, and technically mostly, but it's difficult to cope, or these treatments could overcome the difficulty of the age-related infertility in women.
All right. Once more, thank you so much for this. And well, next question again from the patient. Why is the percentage of aneuploidy high with ICSI?
Yes, through this study that I show you, it was comparing common IVF or classical IVF with ICSI. And it's shown that in these two different groups, the percentage of aneuploidy was higher in ICSI, but this difference was not significant in this study. Okay, and in the medical studies, as you probably know, sometimes we can obtain different results or a result that could be different that we expect, but we should analyze always if this difference could be related to chance or hazard. And in that case, in this group, in this study, they said that this difference was not significant attending this study. Okay, currently I can tell you that probably analyzing the current evidence between classical IVF or ICSI, attending the aneuploidy of the eggs, there are no differences, no significant differences. Okay.
And once again, thank you so much for the explanation to this one. Next question is, so what would be the best option to have a healthy baby for a woman who is over 40?
That's, well, interesting. Probably, of course, each patient should be advised attending different parameters, okay? But probably, as we said, from 40 to 42 years old, probably if we haven't never tried an IVF, probably I will encourage a patient at least to try one IVF round. And depending on the result of this IVF in regards of number of eggs retrieved, result, number of embryos obtained after the end of the culture, maybe we can encourage them to try again. Okay, after 43 years old, as I've mentioned, probably my first recommendation would be always undergo to an egg donation treatment.
Right. Once more, thank you for that question, and of course, your assistance with this. And next one is, I had a natural pregnancy and birth at 42. Since then, I have had miscarriages. Is my only option at 46 old donor eggs?
Yes, interesting. Of course, Claire, natural conception, it's possible and it happens in our societies. I mean, we should differentiate assisted reproductive technology, where we are treating patients where probably there is a fertility problem, from patients that they don't have this fertility problem and they can conceive and have pregnancies at 42, 43, or even more. Okay. Currently, attending your query, if you're right now 46 years old, if you cannot have a natural conception, IVF, undergo to an IVF, probably is not going to offer you any realistic chance to achieve a pregnancy. Many studies performed in this group of patients, they have shown close to 0% of chances for achieving an IVF, a pregnancy after IVF. So answering your question, for me, yes, egg donation should be your choice, or your real choice for in this case.
Wonderful. Thank you so much for this one as well. Next one is in regards to your presentation once more. What do you mean with cumulative live birth?
Correct. Normally, we can analyze the results from different points of view. Okay, an interesting outset. It's, for example, live birth rates or pregnancy rates per transfer. So each time that we perform a transfer, cumulative live birth rates normally is referring to the percentage of success per cycle start. So after transferring probably more than one embryo, because we transfer all the embryos available after an IVF stimulation, including fresh transfer and frozen embryo transfer. Okay, so that's cumulative live rate. This could be applied also to different treatments. So cumulative live birth rates after 2, 3, or 4 attempts. Okay.
Okay, excellent. Thank you so much. And next one is right here as well. So is there a specific time period that the 3 cycles should be taken, or is it just 3 cycles in total, regardless of whether this was over consecutive months or there is a break in between?
This is an interesting question. In fact, some years ago, we were advising our patients to at least leave some gaps in between stimulations. Current evidence published recent years, we've seen that performing consecutive IVF cycles is not going to decrease, or it's not going to be detrimental for the IVF success. Even it could be better, because if we are in a group of people, in a group of patients where the age matters, maybe in 6 months the prognosis could change. Performing these cycles the more consecutive possible maybe could increase also a little bit, maybe not significantly, but a little bit, the chances. So yes, currently the evidence says that it's not necessary, at least in regards of the medical prognosis, to recommend our patients to leave gaps or to leave some months in between cycles.
Again, thank you so much for this. And there's a follow-up. Okay, so how long is it advised to wait between stimulations?
Again, of course, that depends on the result of the stimulation. Of course, if some setback or side effect has appeared, of course, we should attend. We should wait the time we need. Of course, if, for example, after an embryo transfer, a miscarriage had take place, also is not recommended to start. But if simply we have had a negative result, we could start one stimulation after other. It is important. It's not related with in relation with the question, but it's important to bring up that, of course, IVF treatment should be performed carefully. We cannot perform maybe 15 or 20 IVF cycles. It's not recommended, because we know that exposure to high levels of estrogen for a long period of time could bring some side effects in long term. So normally it's said that less than 6 cycles could be performed without any risk of harm.
All right, wonderful. Thank you so much once more for this. Next question is, so I am 28. I have had 3 failed IVF cycles. My MH is 3.14. None of my embryos make it to day 5. I get 15 eggs retrieved, but up to 8 are usually not matured. Do I need donor eggs, or can I keep trying with my eggs?
That's interesting. That is a specific case where we see theoretically a good prognosis patient, but of course, statistics talks about group of patients, and they have to give an idea to give assessment and consult to our patients. But of course, there are specific cases where the quality of those eggs, in spite of probably being normal, there are other factors involved on the quality of these eggs that could impair or explain these results. On your case, probably before switching or changing to donor eggs, maybe some techniques could be applied. Okay, I don't know if you have done that with your patients, but maybe dual trigger or many other techniques could be performed in cases like yours. But finally, in some of them, the only way that we have to help you is to recommend you to switch to donor eggs. Of course, your case, with the details that you are offering me, I don't have enough tools to recommend you to do one thing or another. What I can tell you, but is that undergoing to donor eggs, of course, is going to provide you a much higher chances for a future treatment.
All right. Thank you once again for answering this question and for your recommendation as well. Okay, and let's have a look at the next one that we have right here. Is there any guarantee that embryos will get to day 5 blastocyst?
It's a very good question. It's difficult to tell, because when we retrieve eggs after the egg retrieval, basically the eggs on day 0, the day of the egg retrieval, they don't display quality. So we can only extrapolate if they are mature or not. Okay. So after fertilizing them, we have embryos on day 1 that, again, they only display if they have been properly fertilized or not. After day 2 and day 3, we can start to observe the quality of these embryos. But this quality on day 3, or the score that we can give these embryos on day 3, it has been tested that is not a good predictor of the possibilities of the chances for these embryos to arrive to day 5. Okay, normally blastocyst culture, and I'm saying that honestly and with the evidence that is currently in some places or some countries or some clinics, they have extended the culture till day 5 widely and generally for all patients. And currently, we could tell that not blastocyst culture it could be suitable for all patients, basically, because we cannot know, or there is always the risk that if we take these embryos to day 5 to finally have none of them, because they could be arrested or they could have not enough quality, and we can never know if this embryo from day 3 and above and ahead, the evolution of this embryo could be different inside the uterus. Okay. So answering the question, there is in beforehand in IVF, it's very difficult to predict how many embryos they will arrive to day 5. Of course, the more embryos or the more eggs you could retrieve from the stimulation, the more chances you will have to arrive to day 5.
All right. Again, thank you so much for yet another thorough answer to this one as well. And of course, let's have a look at the next question that we have. Okay, sorry, there's a follow up, okay, from the very same patient. So let me get through this one as well. But if they are donor eggs, is their guarantee for blastocysts supposed to be better quality?
Yes, that exactly. Yes, that depends mostly on each clinic. They can offer different warranties. Okay. For example, in our clinic, it's guaranteed that embryos will arrive till day 5. Otherwise, we will do a new cycle. This happens with a very low percentage of times that we have no embryos to transfer at the end of the culture in egg donation. But yes, it's guaranteed in that case because the donors are studied before. We studied the reproductive background. Some of them, they are fertility proven donors by herself. They have children, or they've done treatments with previous couples, and they offer positive results. So yes, we can offer guarantees in egg donation.
And again, thank you so much for the follow up and your answer to this one as well. Okay, so next question is, so what causes the plateau after 3 attempts between 43 when this is 3 years apart versus someone trying 3 times at 42 or 43 all in 1 year?
All right, let me read carefully the
Sure, of
question.
course.
Yes, all right. Basically, the information that I offer in regards of this is in relation to this is statistically okay. What we are seeing is that again, uh, we're talking in general groups, but there are specific patients. So that means that probably the eggs or the embryos produced by a patient in this group, that these embryos they haven't proved to be enough good to implant and to develop to a pregnancy within these 3 cycles. Probably afterwards this is not going to change, so it's pointless to try, because probably this patient, in regards of their specific characteristics, they are not going to be able to conceive after an IVF independently if the treatment has been performed from 43, from 40 to 43, or within 43, 42 for 43. Okay, of course, the prognosis or the data that I offer you, it was in groups, but of course, a patient in 40 years old has a better, or 41 has a better prognosis than 42 or 43. Okay, so if each patient should be analyzed individually.
Understood perfectly. Once more, thank you for this. And of course, there's a thank you from the patient right here and from the previous one as
You're
well.
welcome, Karen.
All
You're
right,
welcome, Richie.
excellent. And let's have a look. Of course, there are plenty more questions coming up. So let me go to this one. Why would you not recommend PGT testing if the ER resulted in a lower number of eggs?
Okay. ER result in a lower number of eggs. Yes, PGTA. It's a very good question. In fact, it's quite controversial. There are some groups that they recommend to do PGTA in every patient, but the evidence again, and this is evidence coming from important studies from Cochrane revisions, where they are studies very well performed with they include a lot of data. We've seen that PGTA is not a free error tool or technique. Okay, basically because in PGTA, as I've said, you're taking cells from the surrounding area, from the trophobtodem, and we extrapolate that these cells that we obtain, this result could be extrapolated to the whole embryo. I haven't explained that before because technically it's a little bit it's difficult to understand. But within the same embryo, they can coexist different lineages of cells, normal and abnormal. Okay, they are called mosaic embryos, and we've known today that probably every embryo it's a mosaic, so they have different lineages of cells in any moment of in some moment of the evolution. Okay, so we've seen that in young patients, performing PGTA could identify could say that some embryo is abnormal when truly in most of its part it's normal. Okay, but if we perform PGTA, this embryo will be discarded. Okay, so we're gonna rest. So we're gonna limitate the cumulative success rates for young patients. This is the theory, but if we apply this to clinical studies, we see that when we do PGTA, patients older than 38, they will increase the chances per transfer, okay? But in younger patients, if we perform PGTA or we transfer embryos just assessing the morphological quality, we will see that there is no differences per transfer. But if we analyze the accumulative rates, so after transferring all the embryos created in a cycle, fresh transfer, frozen embryo transfer, we will see that the chances for the group in young patients that has done PGTA is less than the group that has done non-PGTA. Okay, because of that, probably because we are removing or we are quitting embryos that could be suitable. This same study has been performed in patients that we call advanced maternal age, 38 years old or more, and we've seen that we increase the chances per transfer, and per cycle start doesn't change. Okay, so that's the reason why we recommend only to do it in this group of patients.
And again, thank you so much for answering this definitely interesting question, as you have mentioned. Next question is, how many M2 sites are needed for a 40-year-old to obtain a blastocyst?
Interesting. Let's see that there is a checkpoint in between what I'm going to answer and this question, and it's the fertilization rates. Okay, so you could have maybe 10, 15 eggs, but if we have a bad fertilization, so maybe 50% only, you will have 7, 8 embryos on day 5. On day 1. It's still, I believe, it's enough for a 40 years old patient. But if we retrieve, for example, just 7, but all 7 they are correctly fertilized and the evolution of the embryos is good, maybe we could have the same result at the end, having a different number of mature eggs. But answering your question, probably, I would say that the minimum of 8 mature eggs. It's an opinion, okay? There are studies published, and basically, in regards of the number of eggs retrieved, you will have a different chance. But the minimum that I believe that could be considered in a page around 40 years old to take this embryos to like 5, maybe 9, 8 to 9 mature eggs will be fine.
All right, again, thank you so much for your question and for your assistance again as well. All right, let's have a look. Of course, there are many, many more questions. I just want to let you know that we will be slowly finishing, okay? But of course, just to reassure you, all the questions that we will not be able to answer tonight, we will forward to Dr. Moreno and his team, and they will for sure get back to you. Okay, so let me now go to the next question that we have. So I have heard that mild IVF up to 225 is better for older women than high dose 300, 450 stimulation. What is your experience with that?
Well, it's an interesting question. First of all, not in my opinion and the current evidence says that no doses higher than 300 should be offered. I mean, 450, most of the studies published, they say that there is no differences between 450 and 300. So 450, I believe that should not be offered to the patients because it's not cost effective, okay? Mild IVF, understood by me and by the conception that we have, probably normally is recommended to do with doses of 150, not 225. 225 will be closer to the classical or the common stimulation than the mild stimulation. I believe that doses of stimulation, they are not going to increase your ovarian reserve. So it's not going to make the ovary offer more than it's able to offer, okay? So if we have a low ovarian reserve, maybe we have 3, 4 antral follicles, probably 300 units or 150 units is not going to change the prognosis. So probably we're going to have the same response or the same result afterwards. So it could be a little bit more cost effective, but this depends on each patient, on each clinic, on the ovarian reserve. For example, only based on due to the age, for example, we could have a patient same age but different ovarian reserve. if I have the chance to retrieve more eggs, I will try to use higher doses, because clearly the number of eggs retrieved is a key factor of success on this kind of treatments.
And thank you so much for yet another thorough answer to this one. Okay, and let's have a look. Of course, there are plenty more of those, and this is the next one. So, what's the average number of eggs retrieved in women at 42 per cycle? My AFC on day 3 was 11, an AMH of 3.1, PMOL, FSH 9.5. How many eggs could I expect on my first retrieval?
All right. It's interesting because these results are a little bit discordant or not concordant, because an antral follicular count of 11 in the tree is really good, okay, but an AMH test of 3.1, it's lower than I would expect for 11 follicles on day 3. Normally, when this case is not rare, I mean, we have these, not consistent results for ovarian reserve parameters. Normally, I rely more on antral follicular count more than AMH. Attending this, of course, I would use in your case high doses of gonadotropins in order, as I've said, because number of eggs is one of the key points of the success on the treatments. But attending only, if I would have only your 11 antral follicular count, probably I would expect to retrieve in mature eggs or an eggs around that, maybe a little bit less, because always antral follicular count, we have a little bit more than normally the follicles tend to grow, but maybe around 7-8 eggs could be expected. Again, this is a prediction, of course. The best marker for a result of an egg donation is to do an stimulation over the patient, because not always the estimation or the parameters they work well in all patients.
All right, excellent. Thank you so much for this. And of course, there's a thank you from the patient for you right here as well. Let's have a look at the next question that we have right here. Is it possible to limit chances for successful treatment both for IUI and IVF based on the AMH value? What would the value be?
That's also a good question. Again, the two factors involved in female fertility, always in regards of assisted reproductive techniques, not natural conception, it's ovarian reserve, so quantity of eggs, and quality. Ovarian reserve, we can know it through FAC or AMH. Quality could be extrapolated from the age. Okay, so based on an AMH, we could have young patients with low AMH, which where they are going to have normally a good prognosis. For example, a patient younger than 35 years old with a low ovarian reserve, probably she's going to have a better prognosis than a patient 40 years old with a good AMH. Basically, in regards of the difference in relation of the quality of the eggs. Okay, so based only in AMH, I will not limit or I will not recommend to do a treatment to a patient, for example, because if she's young, I believe that through inseminations maybe or through IVF, in spite of retrieving a limited number of eggs, we still have good chances to achieve a good result.
All right, again, once more, thank you for this. Okay, and I believe this will be like we have two final questions, okay, and then we will finish. But as I've mentioned, all the questions that haven't been answered, don't worry, you will get some answers from Dr. Moreno and his team. And let me just go to the next patient so everyone has a chance to hear some answers. I am 40, AMH is 8.2, AFC is 11, 5'8", ICSI rounds, no pregnancy. Would you recommend on our egg now? We also had no blastocysts last round out of 9 eggs.
Okay. It's interesting after many transfer perform. Of course, we shouldn't lose the focus of other factors involved in the success of the treatment. No pregnancy. Okay. No blast. So I believe that from your atoms that maybe not always was possible to perform an embryo transfer. So I assume that truly there is an embryo factor, so that these embryos are not working well. They maybe they would not have enough good quality. So probably in your case, yes. After 5 attempts trying IVF, in spite of trying maybe different techniques or maybe different protocols, probably egg donation will be your recommended choice for this. No, attending that this your last cycle, you had 9 eggs and none of them arrived to blastocyst. Also, we should assess the male factor. Okay, sometimes the sperm also can give problems to the evolution of the embryo. So also, I will recommend to assess male factor, of course. And if many transfers have tried, I mean, if you in your previous cycles you were able to at least transfer embryos with failed results, probably assess your endometrial receptivity. I'm not referring to a specific test. It's not there's many ways to assess that. Probably I would recommend also maybe hysteroscopy or an endometrial biopsy. I believe I would offer on your case. But by the way, Carla, I still have some minutes. If there are some questions,
All
I'm
right.
available if you
All
want.
right, just of course, that's not a problem. And actually, there is a follow up, okay, from Maxine. So just give me a second. So, oh, yes, she added that, yes, we have done DNA fragmentation as well.
Okay, and it was normal, I assume.
Yeah, Maxine, if you could let Dr. Moreno know. Sorry, I will double check. Yeah, as in high fragmentation.
So you have had well. This is that could explain the harassment or the bad evolution of those embryos. So we can conclude that maybe there is a male factor also, a hidden male factor. Of course, probably there is a mix between quality of eggs, quality of spermatozoa. There are techniques currently that could try to reduce the fragmentation on the spermatozoa that we use to fertilize the eggs. Maybe could be an option to use that techniques to select better the spermatozoa. But I cannot guarantee that this is going to be the solution for your case. What I could say that if we use egg donation with the selection of this spermatozoa, probably this is the treatment that is going to offer currently your best chance.
Okay, thank you. Actually, there's a thank you from Maxine already as well. Thank you for your advice.
You're
Okay.
welcome.
All right, so let's have a look. We still have a few minutes, so just let me know whenever you can. Okay, you will need to finish. And let's have a look at the next question that we have. And let's go back to this. How do you assign the donor with the mother? Can we choose any features for resemblance?
That's also a very good question. That will depend on the country that you decide to do egg donation. I know the law frame in many different countries. I can explain you in Spain. In Spain, the donation should be always anonymous. That means that the patient cannot choose the donor in a catalog. For attending the current legislation, the clinic should warranty a donor that should share the same physical traits, so the same phenotypical appearance with the recipient, attending different parameters. No, in other countries, the donation is not anonymous, so you can access. You have access to different types of donor and select which one do you want to share your reproductive project with. The anonymous or not anonymous basically is one. It's the issue that is gonna differentiate probably many things on the treatment, price also, and that's it.
All right, so once again, thank you so much for your thorough answer to this one. And let's have a look at the next question from Sally. How much would be the live birth percentage for a woman over 40 who has 13 frozen eggs retrieved at 37, 38?
Right, if you want, well, I have my presentation here. Just let me check the curve. So we've set 37, 38, 13 frozen eggs. So attending this prediction, we are, let's say, 37. Okay, yes, this is the violet one. Attending this study or this prediction model, these chances will be around 55 to 60% of at least having one child. Sorry,
All right.
exactly. Important. What is important is the age when you did the egg freezing, not the age that you are transferring. After many studies, we've seen that the age of the recipient or the woman that received the embryo from herself after egg freezing, there is not a factor of related with the success. So the success will be the same, 40 years old, 45 years old, 43. So that doesn't change.
Excellent. Thank you so much for this again. And let me have a look. And of course, as you can see, thank you from Sally for your right here.
You're
And
welcome.
let's see the next question. So I have recently been diagnosed with endometriosis after 3 fight cycles show that my egg quality has been impacted due to inflammation. My endometriosis has been removed and now I am doing donor egg. Will I still have to worry about inflammation? Immunes with donor egg.
It's interesting. Theoretically, you've said that the endometriosis is still under research, because really we there are many things that we don't know about endometriosis, but it has been published that the inflammatory environment produced by the endometriomas on the ovary could impair the quality or the maturation and the quality of these eggs due to different molecules that they are regulated due to this inflammation on the ovary. Okay. Thanks to that we know, probably, which is said, and what we've seen after clinical trials, is that the eggs produced in a donor that after has been transferred, embryos have been transferred to a woman with endometriosis, they don't have a different prognosis than another woman without endometriosis for the same age. Okay, so it seems that the problem, it's only on the ovary and it's not affecting endometrium and so on. Which we should differentiate, which is different and interesting to tell, is that some patients that they have endometriosis, they could have also adenomyosis, which is focus of endometriosis in the thickness of the muzzle of the uterus. And in these patients with adenomyosis is quite controversial, but maybe they could have a little impairment on the results, okay, due to that. If you have only endometriosis, you shouldn't be worried about this.
All right. Thank you so much for the reassurance here as well. And let's see, there's another question from Karen. What causes the variability in the number of follicles, eggs, in women where the AMH level is the same?
Interesting. AMH it's stable. Basically, the AMH is a hormone produced by the antral follicles. So follicles, very little follicles that they are in the ovary. So the more AMH you have, that means that your population of antral follicles is higher. Okay, but there are other mechanisms that they are not related with hormonal reactions, that they are involved in how many follicles could be available in one determined cycle. We know that there is a variability in between the same patient in different cycles. So for example, the same patient could do an stimulation in one cycle and obtain 10 mature eggs, and the same patient in 2 months could do the same and obtaining only 6. Okay, we know that this is related to this capacity of the ovary of putting follicles ready to be recruited on the stimulation, but we don't know how this is working. Okay, this is a very interesting field. So answering your question, there are many factors involved, maybe environmental even, that could avoid or make more difficult for the follicles to grow. Okay, so patients with same AMH or the same patient could have different results in different cycles. Okay, this variation normally is not very high, it's not dramatic, but could be significant.
And wonderful. Thank you so much. And well, actually, there is a follow up in regards to the previous question, okay, in regards to adenomyosis. So if you could take a look from what you just said about adenomyosis, can we conclude the reverse? Someone with adenomyosis would have high chances of endometriosis?
It's interesting. Endometriosis could appear even without endometriomas. Okay, so classically, when a patient gets diagnosed of endometriosis, only is because they have a cyst on the ovaries where it's identified. But some other patients will have only implants of endometriosis on the pelvic organs, in the rectus, in the uterus, in the outer part, or in the wall, in the bowel. Um, Adenomyosis only is diagnosed when we find this focus in the thickness of the muscle of the uterus. Okay, adenomyosis could appear alone without endometriosis or together with endometriosis. Okay, so answering your question, someone with adenomyosis would have high chances that endometriosis. So um, let's say that for an IVF, probably yes, because the alteration that endometriosis will produce on the ovary could be significant, while adenomyosis, only very advanced clinical cases of adenomyosis could impair truly the receptivity of the uterus. So yes, if I have to choose the lesser, probably I would choose adenomyosis before endometriosis.
All right. Again, thank you so much for the explanation and your
Mhm.
question, indeed, as well.
Mhm.
Okay, let's have a look at the next one. So, what point of embryo cultivation would you recommend third day transfer? Is this defined by the number X retrieved?
Could be defined by the number of eggs retrieved, but mostly it will be defined by the number of embryos evolving. So normally we will check the evolution of these embryos from day one, and depending on the number and the quality of these embryos, I would recommend to extend the culture until day 5, or maybe better perform the transfer on day 3. Also, the age of the patient and the percentage of aneuploidy should be taken account to make that decision.
Excellent. Thank you so much. And let's have a look at the question from Karen. I have tried short protocol and the follicles did respond, although at variable rates. What are the chances of a long protocol with suppression help with more steady growth? I have read that estrogen priming can also help.
Yes, look, short protocol with agonist of the GNFSH, sorry, of the GnRH. Normally, I use it. Well, I never use it almost because of that, because there is always a risk of asynchrony. Okay, because the flare up effect of the discharge with the GnRH and agonist will produce that the follicles could start growing in different sizes. Okay, so probably short protocol, I will not recommend that. Long protocol has been proved to be equally effective as the antagonist protocol, which probably is the gold standard currently. If you do a long protocol, probably estrogen printing, it's not pointless, because basically the estrogen printing, the idea is to keep the FSH level, so the FSH produced by the pituitary gland, by the hypophysis, keep this FSH down until we start the stimulation. It's a kind of blocking as the long protocol, but with less suppression over the ovary. If you do long protocol, your pituitary gland, your hypophysis will be blocked, so you don't need to do this estrogen. Estrogen printing only applies, or it has its sense probably in antagonist protocols.
Understood, of course. Thank you so much once more for that. And again, there's a thank you from Karen. And like few questions left. Let me just have a look, and we will be finishing. So I guess we can go to the next one. Besides all the medical possibilities and statistics, how important is the psychological state of the patient? Do you have any insight in spontaneous pregnancies after the treatment or in breaks?
All right, let me read that carefully. Okay. Yes. Psychological assessment is critical. In fact, in our clinic, and I believe that all clinics should offer that. We work with a with a team of psychologists specialized in this. Of course, offering egg donation treatments for patients is not easy. I mean, of course, for me, it's clear to offer that because only for the medical point of view, I'm offering the best chance to that person. But of course, the conditions that these patients should assume is not easy to take. Of course, I believe that psychological assessment it's critical to help these patients to bear and to make the idea of of doing this kind of treatment. What I can tell you, of course, is that after a successful treatment egg donation, none of them has any complaint or has regrets about what she has done. No? In regards of a spontaneous pregnancy after treatment in breast, it's true that they happen. It's not rare that we see patients, infertile patients, that after IVF treatments, that they were required IVF treatments to get a pregnancy, they get spontaneously pregnant. Probably an immunological factor is involved on that. Okay, this immunological factor, this immunitary system was avoiding on this is theoretically also, but probably was involved on the infertility of that patient. And after having a child, where we do not forget that 50% of the proteins or the structure of this baby, of this embryo, belongs to another person. So it's strange for the woman, and the woman, the uterus and the woman should be an immunomodulation in order to accept that part of the embryo. So after that, this could explain why we have pregnancies after IVF treatments. But answering the question, I do not remember, or very few cases of spontaneous pregnancy after egg donation treatments. So that means that the egg donation should be recommended in where is truly the indication. Okay, and the chances, of course, of a spontaneous pregnancy afterwards, it's quite low.
Excellent. Once more, thank you so much. There are like 3 questions left, and I guess that will be it for today. All right, so let's have a look at this one. What are the percentage of women who froze their eggs after 35 and used them later to give a live birth?
Okay, of course, knowing exactly the age, it's important. But again, what we said, the age where you use your own eggs to transfer is not a factor of success. So you can use it. Let's see, for example, if we said 35 years old, 35 years old has an excellent, quite good prognosis. For example, with 10x, we said that it was 70%. With 20x, it's close to 90% if we freeze. Independently, that if you're going to use it when you're 40, 45, of course, I'm talking of live birth rates. But we should pay attention, as we've said, of the risk of pregnancies in advanced maternal age. So risk, again, premature labor, high blood pressure disorders, and the relation with the health of your future baby. Okay, of course, we can postpone use these frozen eggs for the future, but also we should advise our patients that the later or that we use those eggs, they are exposing to risk during the pregnancy.
Excellent. Thank you so much for this one as well. Let's see. Next question is in regards to supplements. So would you recommend women above age of 42 when preparing for IVF to increase the egg quality?
Okay, what else? Okay, I don't know if this is going to be a quite unpopular. Honestly, there are supplements. First of all, they are not drugs. They are not medicines. They are dietetic or diet supplements. Okay, so that means that not all of them, or probably very few of them, they have been trying in serious scientific trials in order to test the effectiveness of these supplements. No, if I have to tell something, maybe inositol in some group of patients, but well, I will not afford. We have to differentiate that to supplements of B12 or iodine or others that will help your baby to develop healthy during the first trimester of your pregnancy, but probably diet supplements as, for example, DHEA or testosterone. Some protocols they prove to retrieve or to increase the number of egg retrieved, but at the end the live birth rates are the same. So probably exactly DHEA, CoQ10, vitamin D. Vitamin D is interesting also because it's true that some papers have said that patients with a low vitamin D account, they tend to have worse results for reproduction. But when they treat this lack of vitamin D, they don't find an improvement on the chances. So that means that vitamin D is not the problem that we should treat, is a symptom that the problem that we should identify. Okay. DTA normally it's recommended to be taken around 3 months before, 3 months to observe theoretically any positive effect. But again, the current evidence, when we analyze huge series and not only a determined paper, if not huge series and many different studies, they don't have enough scientific evidence to be recommended for every patient. Okay.
Wonderful. Thank you so much. Yes, this is definitely a topic that we could discuss for a lot
Absolutely.
longer. So
Absolutely.
thank you so much for mentioning those. And now it will be our final question for today. So it is, I tend to notice on AFC 1 month low, next month high, and so on. So has there been any studies to show any pattern trend to this variable higher and lower follicle numbers?
Yes, that's again every question is what we have discussed before. We know that when the follicle appears, or we can recognize it through a scan because it has enough measure, maybe 2 millimeters minimum. This follicle, it has been evolving for probably many days and many weeks until it reaches that stage. We should understand which mechanisms are involved in this evolution because they are independent from hormones. No FSH or stimulation will make this antral follicle appears in a determined moment. We know, as you've said, that this could change from one cycle to another, but we don't know why this is happening. We should understand that because with this, maybe we can offer for just one stimulation the maximum chance for this patient. Okay, which is interesting, or a technique or that could be applied. Normally, you could do an antral follicular count just in day 1 or day 2 before starting the stimulation for a specific IVF treatment. It doesn't have a good relation. So if you find, for example, 5 follicles on day 1 or day 2 in this ultrasound, that doesn't mean necessarily that these 5 follicles will grow, because sometimes some of them, they don't have receptors for the hormones, for FSH. But what we are sure is that if you do an antral follicular count and you have 3 follicles in day 2 and you start the stimulation, you cannot expect more than 3. Okay, so this could be a useful tool for patients with very low ovarian reserve in order to decide if we start or not the stimulation for one specific cycle.
And thank you for answering this final question for today. So I already would like to thank everyone for your question. Lots of interesting questions indeed. Dr. Moreno, you have been brilliant. It's been a brilliant session. So thank you everyone for joining and for all those comments, which I will show you, Dr. Moreno, right now. As you can see, there are some thank yous from the patients. So thank you for a fantastic session. Learned so much. Great. Thank you very much. And of course,
thank you. Welcome. Truly, it has been a pleasure. And of course, if that has served you and helped you, I'm happy with that.
Definitely couldn't agree more here that it's been a brilliant session. As you can see, more and more of those thank yous are coming up for you as well. So I just want you to see them. And of course, we will be finishing for today. But of course, remember that if you'd like to get in touch with Dr. Moreno and his team, you can, after this webinar is over, you will be redirected to the website. There is an option for you to contact the team, and I'm sure that they will be more than happy to help you out with some more questions. And Dr. Moreno, thank you so much for joining our Stronger Together initiative and for today, for your time. And I hope you have enjoyed that as well, because I know that this is your first webinar with us. So I definitely hope you will be back with us once more as well.
I hope so.
And is there anything else you would like to add?
No. Honestly, it has been a pleasure. I feel very comfortable, and I will be very pleased to come here with you again if I have the chance.
Excellent to hear this. Thank you so much. And I just want to mention that, of course, this has been recorded. You will find it tomorrow on our website, myivfanswers.com. And also, it will be uploaded on our YouTube channel. So, of course, stay tuned. And if you would like to see more of our upcoming events, of course, you can find those on our website, Facebook, or Instagram. So, as always, it's great to have you here. I do believe it's been very useful for you. Have a lovely and restful evening, Dr. Moreno. You too, as well, of course. Thank you so much. Take care, everyone, and bye.
Bye bye.